Let's move forward, do a quick recap of our routine coagulation testing and move into our special coag testing. So just a reminder, our PT-INR, APTT, fibrinogen D-dimer, and anti-10A, those are all going to be the routine tests that we see very often, but we're going to talk a little bit more about special coagulation testing, and then we'll put it into some practice. Special coagulation testing includes a series of different tests, both for secondary hemostasis, primary hemostasis, and fibrinolysis. So we're going to be able to test every aspect of hemostasis to see where the problem lies in the case that something is amiss. So let's talk about our testing menu. So the first special coag testing menu that we are going to talk about are associated with bleeding disorders. So this would be some, for example, factor assays where we're looking for a specific factor deficiency, PT and PTT mixing studies that can help us determine whether we have a deficiency or maybe an inhibitor, factor 8 and 9 inhibitors. So in the case that we do find factor 8 or 9 inhibitors, we can look for those. Factor 13 screen with that 5 molar urea solution. We are also going to be looking at our von Willebrand factor, antigen, and activity. And remember that von Willebrands we think of as playing an important role for a couple of different things. First of all, it helps stabilize factor 8 in the intrinsic pathway, but also it is associated with the adhesion process of the platelets when they are forming their initial platelet clot. The PFA 100 is going to be associated with platelet function. In fact, PFA 100 stands for platelet function assay. And we are going to expose platelets to agonists that they would respond to in vivo, but we'll do it in vitro. And we will get into all of that fun stuff. And then if we have a platelet function assay test that is abnormal, we're going to see what exactly is it that is abnormal, and we will order a platelet aggregation study and possibly a secretion. This sheet here is kind of a coagulation workup sheet. I do have this posted in your documents as well, so you can take a look at it. But this really kind of tells you all of the things that we're looking at. So for our lupus anticoagulant, we're going to have our APTT, our thrombin time. We're going to talk about normal kind of mixing study results versus abnormal. So this is going to kind of show us what we would be looking at. Say, if, for example, we were looking at a lupus anticoagulant. If in this case, we have a prolonged PTT, we have the normal pool plasma that is 30, and then we have a mixing study that results in a PTT result of 40. So that is a non-correction initially. Then we're going to incubate it for 1 hour, and again, a non-correction. The control is 42, so not correction. That would trigger us to believe that we may have a lupus anticoagulant underlying, and so we might go on to perform this DRVVT. Now, if our DRVVT is test positive, what we might see is first a screening. If our screening is greater than 39.5, we will continue on to a confirmatory test. We're going to divide the result we got for the screen by the confirm on that DRVVT to form a ratio. And if that ratio is greater than or equal to 1.24, we would consider that positive. This ratio is 1.58, which makes it greater than 1.24. So therefore, this would be a positive DRVVT. Now, we may also move forward and do a hex phase. And this kind of depends. We're going to look at some flow charts here in just a minute to kind of talk to you about what our next step or next course of action would be. But in the event that we perform a hex phase, we will run a hex phase 1 and then a hex phase 2. So one of them we're running with substrate, the other without. And if we have a difference of greater than 9, then we would consider that to be positive as well. We may do platelet aggregation studies. We're going to take into consideration the various agonists that help stimulate and promote aggregation in platelets. Amongst those are ADP, collagen, arachidonic acid, ristocetin, and epinephrine sometimes. Now don't get too hung up on this. I'm really just introducing you to this information. We are going to go into a much further study for platelet aggregation patterns and the associated disease states or coagulation disorders. Here are our von Willebrand assays for von Willebrand disease. Here is our PFA 100. We are going to test against the agonists epinephrine and collagen, and then collagen and ADP. And if you notice, ADP and epinephrine are both agonists in that platelet aggregation study as well. So this is PFA 100 is a screening test, whereas the platelet aggregation study is more specific and looks at the aggregation itself against each of those agonists. And then we have a hypercoagulability study. That's going to include our fibrinolytic regulatory proteins, protein C and S, antithrombin, which is one of our natural anticoagulants, plasminogen, which is that precursor to plasmin, and plasmin, of course, is the component that breaks down the fibrin and fibrinogen in those clots that have been formed. APC resistance is going to be associated with a factor V Leiden gene mutation, and we're going to talk about that in more depth, but just know that all of these things can lead to hypercoagulable state in patients, so that's why all of these things are independently tested to see where the problem lies. And then last but not least, this prothrombin gene mutation under this hypercoagulable state. Now, if a patient does have a clot or hypercoagulative state and is beginning to clot inappropriately or even appropriately in some cases, we are going to measure the fibrinogen degradation or the fibrin degradation products with our D-dimer testing. Although fibrinogen and fibrin are both broken down by that plasmin, we are going to measure it only the fibrin degradation products in the form of those D-dimers, which are just the byproducts of that breakdown. The other thing we might look at are our specific factor assays, and if you recall, we do those within 3 dilutions. The dilution it should be within 20% of one another, but if we see a lower percentage of activity with the lower dilution and then an increase as we increase dilution, that may be a dilutional effect of a non-specific inhibitor such as antiphospholipid antibody or lupus anticoagulant. We also do some anticardiolipin antibodies, so some antibody testing, and we do that in special chemistries. So the RB2GP1 immunoglobulin M, class M, and IgG, and then ACA, anticardiolipin antibody, IgM, and IgG. So all of those things are things that we can do with regard to looking for the cause of our coagulation problems. If at any time you need to come back to this sheet and look at it, or the slide and look at it, just to gather some information or take some notes, feel free to. But again, I do have this posted in your lab miscellaneous information so that under COAG so that you can refer to it as needed. All right. So if we have a prolonged PT and PTT or PTT, we can perform a mixing study either for one or both. Most of the time, we're going to see a PTT prolongation, and that's because there are more factors associated with the intrinsic pathway than there are in the extrinsic pathway. We also know that the factor deficiencies that are in the intrinsic pathway occur more often than the deficiencies that we find in the extrinsic pathway. So although we do PT mixing studies from time to time, more frequently than not, we do PTT mixing studies. So this is the way mixing studies work. We've kind of talked about it, and our reason for doing these mixing studies is to determine if the prolongation is a result of a factor deficiency, or are we looking at an inhibitor of some sort. So we will take pooled normal plasma. Now, let me explain what pooled normal plasma is, because you may not know. Pooled normal plasma is an accumulation of plasma that's been collected from individuals, pooled together, measured, and then aliquoted and frozen so that it maintains the integrity of all of those clotting factors. When we take a normal or a pooled normal plasma, we add one part of that normal plasma to a mixture of the patient's plasma, which has been deemed to have a prolongation, let's just say of the PTT, for example. Now we know that that pooled normal plasma contains the necessary clotting factors to correct for a factor deficiency. So if the patient's plasma is deficient in any one of the factors associated with either the PT or the PTT, when we add that mix together, we're essentially replacing everything that the patient's plasma is missing. When we run a PTT or a PT on this mix of one-to-one pooled normal plasma and patient plasma, if indeed it is a factor deficiency, our result will become more normal. It'll be closer to what the normal pooled plasma result was, and so we would call that a correction. And this correction would indicate that there is a factor deficiency because that PNP supplied the necessary clotting factor to the patient sample. Now, if we do a mixing study and there is no correction, there's no change or a very small change, but not a significant change, we could assume that it's not a factor deficiency. Instead, it could be an indication that there's a presence of an inhibitor, such as that lupus anticoagulant. A PTT with correction indicates deficiencies of the extrinsic pathway, and a correction of both an elevated PT and PTT indicates deficiency of a common pathway. So if we have a correction with both the PT and the PTT, then we know we're looking at a common pathway issue. If it's just the PTT, then it's the intrinsic pathway, of course. All right, so let's look at a flow chart for our PTT mixing study. Now, the very first thing we want to do is look into our patient's history, because PTT mixing studies could not be performed if a patient is on anticoagulant therapy. The PTT is a clot-based test, and if we have an anticoagulant in the mix, it is not going to behave in a way that can give us useful information because we're going to have interference from that anticoagulant therapy. If the patient is on anticoagulant therapy, we will cancel this as unacceptable, and then we will just put a comment in that we can't do it and that really the patient needs to hold the anticoagulants before the mixing study is performed. But sometimes we don't know if the patient's on anticoagulant therapy or they're not. So the next question we're going to ask ourselves is the PTT on the original patient sample greater than 39.5 seconds? If it is not, then we're going to cancel that PTT mixing study and we will just report out the PT result of 39.5 or less, and then we will make a comment that the PTT mixing study was not performed because it wasn't indicated, simply because that PTT was less than 40 seconds. But if the PTT is greater than 39.5 seconds, we are going to go ahead and do that one-to-one mix with that pooled normal plasma. After we mix the pooled normal plasma and a sample and with another part of patient sample, we are going to run another PTT. Is there the difference between the PTT the PTT mix. Hold on, let me repeat that. I totally just floofed that up. If is the difference between the normal pooled plasma PTT, meaning just the pooled plasma, because we run a sample on the patient by itself, the PMP by itself, and the PTT with the mix of the PNP, and then we compare them. So we are going to say, okay, after we do the mix, is it going to be less than or equal to 5 seconds from the PNP PTT, which should be normal, right? If not, we report it as no correction. If it does, we still can't report it as a correction quite yet. We're going to incubate it for 1 hour to rule out a factor inhibitor, because remember, factor inhibitors are very, very dependent upon temperature and time. And the longer we incubate them, the more time those inhibitors have to actually inhibit the factors that are present. So that is why we incubate it, even if we see an initial correction. Are the incubated mix and control results within less than or equal to 7 seconds of each other? If yes, we can report now our PTT mixing study as a correction, which would indicate that we have a factor deficiency somewhere in the intrinsic pathway. And if no, then we will hold it for pathology to investigate for a possible factor inhibition or inhibitor. All right, I hope that made sense. If you need to, come back and take a peek at this. This is also posted as a document in your resources. So take a look at that. All right, so our PT mixing study, again, this is also a clot-based test. If the patient is receiving anticoagulant therapy, we do cancel it most of the time, but although it's usually not performed on patients receiving anticoagulation, there are some exceptions that do exist. So if the physician insists that we do it, or if they're on a different type of anticoagulant that wouldn't affect the PT, we may do a mixing study for those patients at the doctor's request. But ordinarily, we would go ahead and not perform it if the patient is receiving anticoagulant therapy. If they are not, or it's unknown, we're going to ask ourselves this: is the PT greater than 15 seconds? If not, we're going to cancel it because it's not indicated for a PT mixing study, and we will just comment not performed because PT is less than or equal to 15 seconds, and we'll just report out the pro time result that we received initially. If it is greater than 15 seconds, we're going to do that 1-to-1 mix with our patient sample and our pooled normal plasma. Is the PT 1-to-1 mix less than or equal to 2 seconds of just that PMP pro time? If yes, we're going to report it as a mix. And if no, we're going to report it as, if yes, we're going to report it as a mix that corrects. And if no, we're going to report it as no correction. If the PT is extremely elevated, we're going to hold it for supervisor review anyway, just to make sure that there's no instrumentation problems, or make sure that we've done everything that we can do to get valid results on this. And it might be that the patient really is on anticoagulants that we don't know about. So it's important to know what's going on with our patients. You might notice here that we don't have that incubation step that we had during the PTT mixing study, and that's because the reason we do that incubation is just because of the prevalence of factor 8 and 9 inhibitors. There are other factors that can be inhibited, or other factor inhibitors, excuse me, but we do that for the intrinsic pathway factors because they are more common. I know I have mentioned factor assays, but let's talk more about them. So how do we know if our factor assay is normal or abnormal? First of all, we need to determine which results we would put out, especially because we typically run factor assays at 3 different dilutions. The reason we do this is to rule out a non-specific inhibitor. But what if we run our 3 dilutions and then we have a result? How do we know which one to put out? Well, we're going to start with the most basic concept of instrumentation, and this is going to be starting with our calibration curve. Now, most calibration curves are measured from low to high, so we have a low to a high line or linear progression. In the case of our factor assays, our calibration curve usually starts higher and then decreases in percent activity. So the x-axis is going to be concentration in percentage, and then our measurement on our y-axis is going to be measurement in seconds. So at the very top of our, so let me see here. Okay. So if you look at this kind of grid at the very bottom, we're going to see that our calibration curve starts at the top of at 110% and then goes all the way down to 7% at the bottom of the line. And it also shows you here our linear equation. You don't have to do that right now, but you should know that from your analytical chemistry class, or maybe you had an instrumentation class. But either way, the beautiful thing about calibrations is that the calibration numbers come in an acceptable range from the manufacturer who produced the reagents, and the calibrations have been repeatedly tested for accuracy and precision so that we have a nice distribution of data points and we can confidently say that this calibration curve is accurate and precise and that the concentrations found there are going to behave appropriately. The reason we do calibration curves is really just to make sure that all of our instrumentation is working appropriately and that our reagents are working. If for some reason we try to do a calibration and our calibration doesn't fall within the normal or acceptable range of the calibration given to us by the manufacturer, we know that perhaps there's a problem with our instrumentation and we need to look at the possibilities and maybe call service or something. But this is a normal calibration curve. Everything looks great. Instrumentation is great. Our value is 1.0, which is ideal. It just means it's perfectly linear. And our range on the calibration curve is 110% at the top to 7% at the bottom. So before you do anything with factor assays, you need to know what your range, your calibration curve range is. Okay. When we have a normal calibration and we've got QC, quality control, that works, we are going to run those factor assays at 3 different dilutions. And all of those dilutions must be within 20% of each other to be considered linear, okay? The lowest dilution that falls within the calibration curve is the one that we report. So that's why it's important for us to know what range our calibration curve falls under. But most of our dilutions are run as factors of 10. So we really have to do just a tiny bit of math, but don't worry, I will make it easy on you. Let's look at the next page so that we can determine which of the dilutions we need to report. All right, so our factor assays, with regard to interpreting results, let's talk about a couple of things. We are going to do those 3 linear dilutions. Hopefully they come out with linear results. And the important thing to note is that the base factor dilution is a 1 to 10 dilution. So that means if you have a 1 to 10, you get a result of 120% factor activity, that is your answer, because if you were to divide this to get to your factor of 10, it would just be 1 in the denominator's place. But If you have a dilution factor of 20, you would divide the result by 124. So 124 divided by 2 is going to be 62. 62 would fall on the calibration curve, because remember, our calibration curve is 110 to 7. 120 would be too high, so it would fall outside of the linearity of that calibration curve. And if we were to divide 122% by 4, that is 30-ish, 31-ish. That is also on the calibration curve. Now, if you have 2 points or 2 results of or 2 dilutions that fall on the calibration curve, we are going to choose the lowest dilution. So the answer in this case would be a 1 to 20 dilution of 124% activity would be the reported result. Now, don't get confused, because when we do the dilution and we do that division, we're not looking to report out the number we get for dividing. We're only dividing it by that factor of 10 or by that dilution factor so that we can see if, in fact, it actually falls on the calibration curve. Does that make sense? Let's take a look here at number 8, factor 8. So the first one is a 1 to 10, and it is 12%. The 10%, so we're really going to just get our divisor. So we're going to divide, because it's not in a factor of 10 at this time because it's a very low dilution, 10 divided by 0.5. So it's going to give us a value of 20. And yes, that does lie on the calibration curve. And then 13 divided by 0.33. That's going to be closer to 40. So we would choose the 1 to 2 dilution because it's the lowest dilution and it is on the calibration curve. And last but not least, there's one more. We have factor results. We've got 1 to 20, 1 to 40, and 1 to 80. This might be something we see when a patient's having, when factor 8 is exhibiting acute phase reactivity. So we're going to have a higher percentage of activity. But let's just say, for example, we have our 252 is going to be divided by 2. That gives us 126. That is above linearity, because remember, our top number on our linearity is 110. We'll have our 236, and that is going to be divided by 4. So that equals 59, and our that does fall on the calibration curve. And then 245 divided by 8 is 31. So both the dilutions of 1 to 40 and 1 to 80 fall within the calibration curve. However, when we have 2 values that fall in the calibration curve, we are always going to choose the calibration that has the lowest dilution, and that would be the 1 to 40. Now, if we perform a dilution and our results look like this, our series of dilutions look like this. We have 1 to 10, which is our lowest dilution here, and we're getting 15% activity. 1 to 20, it's increasing. 1 to 40, it's increasing further, and so on and so forth. So we see all the way up to 180, we're starting to see an increased dilution, but also an increased activity. This is an example of what we would see for when a non-specific inhibitor, such as a lupus anticoagulant, is present. As we get more normal, we would start to truly see this as probably the true factor level, and we would have to request approval from from our pathologist to report these results. Now, sometimes we have results that fall outside of linearity. And because our calibration curve runs the opposite direction of most calibration curves, it runs from high to low versus from low to high, we are going to look at those results. And when we have a high value, it's going to report it out as V is less than V min. So you like, well, that doesn't really make sense. It's minimum. Well, that's because our calibration curve in this case runs from high to low. Now, factor assays are the only calibration curve for most of the COAG testing that runs from high to low. And so the opposite would be true in the other assays that we run, like our PT or PTT, all of those. We would see a V max. V is greater than V max, meaning the value is greater than the maximum value if it were high. But in the case of factor assays, when you see a V is greater than V max, that means it is actually below linearity. I hope that made sense. I feel like I stuttered through that for some reason, but let me know if you have any questions about that so I can give further clarification. In the event that we are performing our factor assays and we come across low activity despite perhaps being given recombinate or Benefix for hemophilia treatment, we may be suspecting a factor 8 or factor 9 inhibitor. These are very specific factor inhibitors that inhibit factors 8 and factor 9, and these inhibitors can be developed in hemophiliacs due to the treatment or alloantibodies formed against those specific concentrates that are given for replacement therapy. And acquired hemophilia can occur in patients who develop an inhibitor due to an autoantibody. So this can be autoimmune or can be alloimmune acquired. What we would likely see in these patients is we would see low factor activity, and most of the time we would be able to investigate patient history. Obviously, they may have a sign of, they may have a history of factor replacement therapy. That's usually the most common cause. But if not, we do have the testing that we can do to kind of confirm our suspicions as to whether or not there is or isn't an inhibitor for our specific factors. All right, so if you recall, we did talk about factor 13. Factor 13 cannot be measured or evaluated through the PT or the PTT. So we use a factor 13 screen, essentially where we stimulate coagulation to form clots in vitro, and then we expose that clot to a 5 molar urea solubility test. In the absence of factor 13, those fibrin strands will not be stabilized or polymerized, and they will be dissolved by that 5 molar urea, which disrupts the hydrogen bonds. Because remember, factor 13 will come in and replace those hydrogen bonds with covalent bonds to give it structure and stability. The assay is abnormal when factor 13 levels are less than 1 to 2%. And a normal result will equal a clot surviving equal to or greater than 24 hours. And the abnormal result, the clot would not survive the full 24 hours. And again, if you remember, we did this one in our student lab activity, your PET clots. And I'm happy to say that everyone survived this term. All right, so our von Willebrand factor antigen and activity, we're going to be looking for a variety of subtypes of von Willebrand's disease. We can test both quantitatively for the antigen and qualitatively for the activity of von Willebrand's factor. And we often order it in correlation or in association with our factor 8 assay as well, because oftentimes when there's a decreased antigen or activity in von Willebrand factor, we see a decrease in factor 8 as well. Because remember, von Willebrand factor helps to stabilize that factor VIII. Low levels of von Willebrand factor antigen activity and or factor VIII indicates a diagnosis of von Willebrand's disease. It gets a little bit more complicated than that, but for now, this is the big picture of what you need to know about testing. Although we haven't really discussed platelet function because that is part of our primary hemostasis, we're going to go there next. Let's just do a brief overview about some of the testing that we can perform. So the most common type of platelet testing is going to be in the form of platelet function assay or PFA 100. And the way that platelets behave in vivo is in response to certain chemical signals. And some of those are in the form of contact signals, others are in the form of hormones, etc. And we call these agonists. These are things that stimulate platelet function. And there are a couple of agonists that we use in the PFA 100 to kind of tell us about, a little bit about basic platelet function. These agonists are collagen, adenosine diphosphate, and epinephrine. So all three of those things can trigger a response for the platelets to activate. Now the screening for this test is looking basically for very much things like von Willebrand's disease, maybe aspirin-like defects, and there are a few others that we're going to talk about, but overall we don't really get too much information about the platelet function other than it's abnormal versus normal. And it may be normal in response to one agonist and abnormal in response to the other, but if it is abnormal in either regard, we still consider it to be abnormal and further testing might be ordered. It essentially measures the amount of time it takes for platelets to close an aperture across a membrane that is embedded with collagen. And this is essentially replaces the bleeding time. Now, if you would please go ahead and watch this video link that is embedded here in this slide, because it will show you the PFA 100 and kind of how that aperture closure takes place when we're measuring our platelet function. All right, again, we haven't really talked much about platelets, but after we do a PFA 100 screening test, if that comes back abnormal, we are going to do further testing with regard to platelet aggregation. So platelet aggregation has to do with platelets coming together to form that primary hemostatic platelet plug, and then that would be what we would consider the primary wave of platelet aggregation or platelet activity. And then the secondary wave would be the secretion of the platelet granules. So platelets have some alpha granules, a few different types of dense granules that hold different chemical components, which aids in their function and also kind of like recruiting other platelets to come. It also helps activate certain aspects of the coagulation cascade. So there are a few different things that happen there, and we're going to go into much deeper detail once we get into our primary hemostasis. And again, this platelet aggregation is going to be test is going to be very specific. It's going to show us patterns of aggregation that are specific to certain platelet disorders like von Willebrand's disease, Glanzmann's, Bernard-Soulier, and there are a couple of others as well. Unfortunately, we can't perform this on patients with low platelet counts because obviously if there are no platelets there, we can't really measure their activity or their function. And we do have to use platelet-rich plasma, so that platelet-rich plasma has to have at least 100 platelets or more. We use some of the same agonists in the platelet aggregation test that we do in the PFA 100, and then we add a little more. So the agonists that we use are ADP, collagen. We also use arachidonic acid. We use ristocetin, and if the doctor asks, we go ahead and use that epinephrine again. And then we will look at the platelet aggregation pattern that is demonstrated. and that will help us kind of narrow it down to what kind of platelet disorder this patient may have. And again, take a look at this video. It's pretty interesting. The interesting thing that I love about platelet aggregation, although platelet aggregation testing does take some time, we can actually see the pattern of aggregation happen in real time. We utilize little glass cuvettes. It is a spectral photometric measurement, and you can actually, when you're done with the testing, pick the cuvette up, look at it, and you can see macroscopically the aggregated platelets, and it's just really neat. We also get a real-time graph of platelet activity in response to each of the agonists. So that is just, I think it's a really fun and neat test to look at. Okay. Now we are going to look at our hypercoagulability test menu. So this is a little different. These are things that are going to be associated with malfunction of our regulatory system, our fibrinolytic system. We've got antiphospholipid panel testing. We have protein S, which is one of our regulatory cofactors. Both the activity, free and total protein S, protein C activity and antigen, antithrombin, which is one of our normal natural anticoagulants, and then APC resistance, which is basically a test to see if factor V has a resistance against activated protein C due to maybe a gene mutation like factor V Leiden. Factor C, or protein C and protein S, are cofactors, and they have to go one with another. They regulate factors 8 and 5. And so if there is a deficiency of those, they aren't there to regulate the coagulation cascade at levels 8 and 5, or factors 8 and 5, and therefore things can get out of whack and hypercoagulability can occur. Same thing with antithrombin. If it is in abnormal volumes, like we don't have enough of it, it can't do its anticoagulant activity. Antiphospholipid panel is done for antiphospholipid antibody, which can stimulate coagulation due to interactions with phospholipids on the surface of the membrane of platelets. So all of these things can kind of show us where the balance is no longer able to be kept in check, and therefore coagulation gets out of hand. Let's talk first about the antiphospholipid syndrome. Patients present with a prolonged PTT, but it's actually a clotting disorder. It is a hypercoagulable state of being. What happens is autoantibodies interact with platelet membrane glycoproteins, and that can cause an increase in platelet aggregation in vivo. So stimulates platelets to start clotting or coming together. In vitro, however, the antibodies react with the phospholipids in the PTT reagent, thus prolonging the result. So it isn't really that clotting is prolonged or that it takes longer to clot. It's just that it appears that way when we're doing our instrument testing, and it's only because of the way those antibodies interact with some of our reagents. But inside of the body, where it really counts, this actually interacts with those platelet membrane glycoproteins and stimulates platelet aggregation, which leads to excessive clotting sometimes. So we need to have multiple tests that are positive at least 12 weeks apart to confirm the diagnosis of an antiphospholipid syndrome or an antiphospholipid antibody. But what are we going to do if a patient has one? Well, let's see what else we can do. What other testing is involved in this antiphospholipid panel? Okay, so the antiphospholipid panel is commonly ordered as a special coagulation test that's looking for that lupus anticoagulant. We also can call that maybe a non-specific inhibitor. Now, this panel can include a variety of things. We actually have a couple of different versions of this test. Obviously, we're going to start out with a PT-PTT. If the PTT is prolonged, we might then have a PTT mixing study performed. And if we do that PTT mixing study and we have no correction, that would rule out any type of factor deficiency, but it could be, indicative of a lupus antibody or lupus anticoagulant. Thrombin time is going to be elevated if patients are receiving heparin, so it's going to be usually over 60. Our DRVVT, our dilute Russell Viper venom time, will be positive, a positive result. In order to have a positive result, we have to have a ratio of greater than or equal to 1.24. Anything less than 1.24 would be considered negative. And then our hex phase or our hexagonal phase phospholipid would need a positive result to indicate lupus anticoagulant. And for that, we run two, one with substrate, one without, and then we calculate the difference. If the difference is greater than or equal to 9, then the result is considered positive. So a normal hex phase would be less than 9. We can also include special chemistry testing like B2GP1 and ACA testing or anticardiolipin antibody. And this is beta-2 glycoprotein 1. So we're looking for any type of antibodies against those phospholipids. And again, here's just those results for that lupus anticoagulant testing. So we would calculate that DRVVT as a ratio. So we would run a screen and a DRVVT to confirm, and then we would calculate the DRVVT divided by the DRVVT confirmation. If the screen is less than 44, we don't really need to run that confirmation. We can just go ahead and consider it to be negative. But if the screen is greater than or equal to 44, we're going to confirm that testing and perform that ratio calculation. If the ratio is greater than or equal to 1.24, we do consider that to be positive for lupus anticoagulant. When we perform a hex phase, these results are calculated as a difference between hex 1 and hex 2. And again, hex 1 and hex 2, one of them has got substrate added, the other has no substrate. And if there's a difference of greater than or equal to 9, we consider that to be a positive result for lupus anticoagulant. So keep all of those values in mind. Hopefully, once you get out onto the bench, maybe we can talk more about it, and I could even give you a demonstration if the time permits. Okay, so here's some of the criteria for the laboratory diagnosis of lupus anticoagulant. Again, that's a non-specific inhibitor. We're obviously going to have a prolongation of the PTT, and the PTT is a phospholipid-dependent clotting assay. There may be evidence of an inhibitor demonstrated by a mixing study. So again, that PTT mixing study is going to be no correction. There may be evidence of a phospholipid-dependent inhibitor based on neutralization of the inhibitor effect with added phospholipids. So again, our factor assay dilutions, we're going to see an increased activity with increased dilution, so neutralization of the inhibitor. And then lack of specific inhibition of any one coagulation factor. So we're going to see inhibition with many factors, not just one specific factor. So antiphospholipid testing can seem a little bit confusing. So I have provided you with this APL flowchart. First thing is we are going to ask, is this patient on any direct thrombin inhibitor or anti-10A inhibitor other than heparin? If the answer is yes, we cannot perform clot-based testing. If the answer is no, next we're going to ask, is our PTT less than 39.5? If it is, we're going to go ahead and perform our DRVVT, just the screen initially. And again, if our screen is less than 44, we're not going to do the confirmation. We'll just report it out as negative. If our PTT is not less than 39.5, we're going to look at what are the values. So we have two options. We can either have a PTT of 40 to 109 seconds or a PTT of greater than or equal to 110 seconds. Let's look first at the PTT of 40 to 109. Is the patient on heparin? Well, if the patient is on heparin, we're going to go ahead and perform a hex phase. If the patient is not on heparin, or if we don't know whether or not the patient is on heparin, we're going to do that thrombin time. And if that thrombin time is greater than 60, that would be indicative of the patient being on heparin. And if that's the case, we would go ahead and perform that hex phase APL. Now, if the thrombin time is not greater than 60, we're going to have to perform a PTT mixing study. If the mixing study does not correct, we would report the PTT mix as no correction, and then we would refer to the separate hex phase APL flowchart, which I don't have posted, but I will post it for you if you have an interest. And then the PTT, if it does correct, we're going to go ahead and just report out that the PTT mix has corrected. Now, if we have a PTT of greater than or equal to 110 seconds, we're going to ask ourselves, is this patient on heparin? If yes, we are going to result the PT, PTT, and the mixing study equals no, and add the mnemonic lupus anticoagulant with heparin and canceled the reflex test per protocol. So we can't perform all of this if the patient's on heparin. We'll just go ahead and report out the basic testing. If they are not on heparin or they're unknown, we're going to perform that thrombin time. If the thrombin time is greater than 60, we are still going to cancel. And then we will just report out the PT, PTT. And then we will perform the PTT mixing study if it is greater than, if it's not greater than 60. And then after we get past that PTT mixing study point, we are going to report it out as a correction or no correction. Okay, protein C. We haven't talked much about it because it's really an important part of our fibrinolytic system, but we'll get there. But let's first kind of talk about what protein C is and how it can contribute to a patient becoming hypercoagulable, meaning overclotting. Protein C deficiencies can cause patients to be hypercoagulable because they are one of the primary proteins that regulate or inactivate active factors 5 and 8. So coagulation's going along, protein C comes in and is like, hold on the brake, boys, we're done, we don't need to coagulate anymore, and factor 5 and 8 are inactivated by protein C. Protein C is kind of tricky because it is also vitamin K dependent, even though it's more of a cofactor than an actual COAG factor. It's more kind of like a regulatory protein. But we can have acquired deficiencies that are secondary to warfarin therapy. So remember, warfarin acts upon that extrinsic pathway. Well, we see activity of protein C in the intrinsic pathway against factors 5 and 8, right? But protein C actually degrades faster, is affected more or earlier on than factor 7. So what happens is in the initial instance that a patient is receiving warfarin therapy, factor 7 is really the target, but protein C degrades first. Now, when protein C and protein S, which is a cofactor to protein C, we'll talk more about that here in a bit, when they degrade, there are no longer any regulatory proteins to take action against active factors 5 and 8. And so in order to prevent this hypercoagulability, we really have to overlap warfarin use in the beginning with with heparin. So warfarin we're first going to see a decline in protein C, and then it'll take a while for protein S and then factor 7 to decline. In the meantime, we have to depend on other means of anticoagulating until that factor 7 has been acted upon by warfarin, and then we're anticoagulated at a therapeutic level, and we don't have the chance to become hypercoagulable due to that protein C degradation. Protein C activity is basically the measurement of the functional activity of protein C, so it would be more qualitative in nature. And the way we do that is we take that snake venom and add it to patient plasma, which then specifically activates protein C to be measured. So we're looking at the functionality. We call this a functional chromogenic assay. And then we have a protein C antigen immunoassay, which is an ELISA test. So we have coded wells looking for that protein C antigen. Activated protein C resistance. Okay, so this one's kind of important. It's initially used as a screening test for factor V Leiden gene mutation, and there are a few reasons for that. This activated protein C resistance test can actually give us a lot of information about how our body is utilizing or how it's responding to active protein C or activated protein C. There are some conditions that cause us to be resistant to activated protein C, and so unfortunately protein C can't regulate factor V specifically and factor VIII. What happens is we are first going to do that activated protein C resistance test, and that's because molecular testing is more expensive and it's more specific. We want to make sure that we're going in the right direction. Initially, when we suspect a factor V Leiden gene mutation, we will first do this activated protein C resistance test. If this comes back that we are found to be resistant to activated protein C, we'll go on to do genetic testing for that factor V Leiden gene mutation. Now, what that factor V Leiden gene mutation actually consists of is just an amino acid substitution in that heavy chain for the factor V. It's the most common cause of inherited thrombophilia, meaning hypercoagulable disorder, about 20 to 50% of the cases. Remember, this activated protein C resistance test is not a test for protein C, but rather it's testing for the mutation of factor V. And the reason why we are utilizing protein C activity or activated protein C to look for resistance is because when we have those amino acid substitutions, we also have changed the function of our factor V protein. And that allows factor V, which used to be able to be inactivated by protein C, to now become resistant to becoming inactivated. So factor V has run amok. Our reference range is we want a APC of greater than 2.50 to be considered normal or non-resistant. But a low APC result automatically gets reflexed to factor V Leiden PCR. And yes, we do that testing here. It is molecular testing, and we do quite a few of them. Another part of our fibrinolytic pathway that we haven't really talked too much about, but we will get there, is protein S. And it is a cofactor to protein C. Where protein C goes, protein S goes, and vice versa. Patients will become hypercoagulable if protein C and protein S cannot form a complex one with another. The reason why is protein C and protein S cannot function. They're just very codependent. Let's just put it that way. They can't go anywhere together. They are conjoined twins of the fibrinolytic system, and if one is deficient, then the other will not be functional as well. or at least until substrate is utilized, and then we'll have excess of, say, protein C, but we won't have enough protein S to complex our excess protein C with, so it can't be activated. And therefore, factor 5 and 8 inhibition cannot occur at normal levels. We might have some inhibition because if we're just a little deficient, we'll still have some protein S that can complex with the protein C that's available, but it won't be to the extent maybe that is necessary. And so these patients might still be at an increased risk for thrombosis. It can also, again, for the same reason, be acquired deficiency seen in patients on warfarin. So as I said, protein C is the first to go, protein S, and then later in a day or two, we see a decline of that factor 7, which is the true target. But unfortunately, because they degrade a little faster than factor 7, patients can become hypercoagulable for that short period of time. The solution to that would be just overlap heparin therapy in addition to warfarin therapy until the anticoagulation has come to a therapeutic level with the Coumadin itself. We have a couple of tests to check for protein S. We have the functional assay, which is protein S activity, and then we have antigenic, which is going to be protein S free and total. So we're going to be looking at the unbound or uncomplexed protein S and the protein SC, protein S free. And then we're going to be looking for the total, so both the complexed and the free. So the free that does not have a complex with protein C, and then also the one that's complexed with protein C. Antithrombin. So antithrombin is one of our natural anticoagulants, and it acts as the main inhibitor of thrombin. Now, think way back. Recently, we just talked about thrombin. Thrombin does all things. It's associated with primary primary hemostasis, secondary hemostasis, fibrinolysis, and antithrombin. Think of him as the kryptonite of thrombin. It is a natural anticoagulant that acts as the main inhibitor of thrombin. And the funny thing about heparin is not actually an anticoagulant. Heparin complexes with antithrombin and amplifies the anticoagulant activity of antithrombin. If a patient is deficient in natural antithrombin levels, they may not respond to heparin. You may give them higher and higher doses of heparin therapy, and they may not respond by anticoagulating in the way that you would expect. Deficiencies of antithrombin can be inherited or acquired. So more common things like DIC, liver disease, etc., which are acquired. But deficiency can be also inherited. Our reference range is usually 80 to 130% activity. Just a couple of more tests to go, but we have honorable mention factor 8. Elevated factor 8 levels can indicate that a patient is in a hypercoagulable state. However, because it is an acute phase reactant and therefore is increased in acute and chronic inflammation, we no longer utilize it as part of our hypercoagulability panel. But the important thing to note is that when factor 8 is elevated, it is generally not clinically significant because of its ability to act as an acute phase reactant. So pregnancy, hormonal birth control pills, chronic inflammation, so many things that can cause that acute phase reactivity to happen. Yes, it is true that a patient could be at an increased rate or risk for coagulable or hypercoagulability, but in most cases, it's not the issue. All right, the last test that I want to talk to you about is the P2Y12 test. This test for platelet inhibition for patients taking clopidogrel, and that you might have heard it called Plavix. So what clopidogrel does is blocks that P2Y12 receptor on the platelet to prevent platelet aggregation. And essentially that gives given to patients to prevent clotting. Now, when looking at our values for our P2Y12 testing, values of less than 230 are going to show that platelet inhibition, that P2Y12 inhibitor effect. And a lot of times we want to check these P2Y12 levels prior to surgery because sometimes patients who've been taking Plavix or clopidogrel may demonstrate platelet inhibition and will be more prone to bleeding complications. So it's really important that physicians be prepared in case there are any hemorrhagic tendencies for these patients. Most of the time, these patients are um, it's requested that they hold their medications for a period of time, but it really just depends on the patient history and the physician's um, demands. All right, so that wraps up our special COAG testing. If anyone has any questions, feel free to email me. We can talk about things in class. Um, we are now going to move on to our primary hemostasis, and hopefully now that you know about the testing, everything's going to fall into place. Have a great day.